Hello, everyone, and welcome to the live Q&A session on modifiers. My name is Kristen Robinson. I have my CPC, CPMA, CCC, CRC, CEMC, and I'm also an approved instructor. And this is being provided from the Coding Corner. That is my personal Facebook page if you would like to hop over on Facebook and check it out. So, just some housekeeping for everyone that is currently attending the live call. This is a recorded meeting. It will be posted to YouTube post the call. This is an open forum specifically on modifiers. So, anything modifiers goes. All modifier related questions are allowed. Please make sure to be respectful of others. Only polite discussion is allowed. And a copy of this slide deck can be provided at the request of the live attendees post the recording. So just a quick disclaimer, the information given within this presentation is known to be current and accurate as of today of the presentation. CPT modifiers are copyrighted by the American Medical Academy and are updated annually, and this information in the presentation is not considered authoritative and should not be used as such. So we're going to go into evaluation and management modifiers first. I did create a general topic slide deck on each of the elements that we can discuss. But like I said, this is an open forum. Therefore, any evaluation and management modifiers in this section are going to be allowed. So first modifier we're going to start discussing is modifier 24. Like I said, you're welcome to come off mute if you have specific modifier 24 questions, but as a starter, I am going to go over the basic definition on the slide, and then you're welcome to ask any questions that you would like. So modifier 24, what is it? This is an unrelated evaluation and management service by the same physician or other qualified healthcare professional during the postoperative period. So when we are discussing modifier 24, modifier 24 is specifically for the provider or provider practice, same specialty that performed the global surgery that put the patient in global to begin with. So when we talk about modifier 24, if a provider sees the patient during that global period, the only way they can bill that evaluation and management service with a modifier 24 is if it's unrelated to the procedure. It can't be due to adverse effects, complications, or otherwise related directly to the procedure. It would have to be for a separate indication other than anything related to the procedure. So keep in mind that documentation has to be appropriate in order to get this modifier billed. A lot of providers want to get that separate E&M service, but when it comes down to it, the evaluation and management follow-up post-op care, they have already gotten paid for. When a provider is paid for that global surgery, that 90 days of follow-up is part of that paid procedure. So unless they are truly doing something separate from the indication for surgery, adverse effects, or complications, they should not be billing evaluation and management services with a modifier 24 while in global. So I haven't seen any particular questions on modifier 24. Keep in mind that we will discuss sending out the slide deck post the call. So are there any questions that anyone would like to bring up as it regards to modifier 24? If not, I can move forward to the next modifier. I'll give it just a minute and then we can move forward. Okay, so modifier 25, this is a big one. This is probably the most abused modifier for evaluation and management coding. Every provider wants to put a modifier 25 on their services, believing that it is truly separately identifiable. Okay, so the definition of modifier 25 is a significant, separately identifiable evaluation and management service by the same physician or qualified healthcare professional on the same day of the procedure or service. Now, keep in mind that the situations where this is being abused is if a patient is coming in for a pre-planned trigger point injection or a pre-planned office procedure where they have already made the decision to do it on today's visit, unless the provider is performing more than the normal workup for that procedure, it's not going to be separately billable. So if the provider is also addressing separately indicated chronic conditions or a new acute condition, they're prescribing medications that are outside the realm of what would be necessary for the procedure on that data service, or they're doing other follow up from something other than today's procedure. Now, remember that when we say procedure, we say that in the sense of it having a less than 10-day global, so a zero global day procedure. That can be injections. For instance, that can be your influenzas, your other immunizations. They also require the 25 modifier on your E&M service. If they're doing a trigger point injection or they're doing a biopsy, they're doing any type of office procedure that does not have global days attached, and it is done on the same day as the evaluation and management service. We need to make sure that our providers are appropriately documenting a significantly separate service. What I tell people whenever I'm educating them is if you were to erase everything in that note related to that procedure done on that day, would you have enough documentation left to support a significantly separate evaluation and management service? Okay, so now I'm going to open it up. Does anyone have modifier 25 specific questions? Now, remember, this is an open meeting, so I would love to have some people either drop in the chat or come off mute and ask some questions. Wonderful. I'm glad that that was helpful, Selena. So basically, there are a couple other things I want to cover on this particular slide that apply to different scenarios. So in the case that they make decision for surgery for a procedure that has a 90-day global on it. So if they make the decision for surgery the day prior to the procedure or the day of the procedure, you would not be using a modifier 25 if it has global days attached. Instead, you're going to use modifier 57. Modifier 57 tells the insurance that decision for surgery was made. Now, the caveat on that is that you can't use modifier 57 if the decision for surgery was made 2 weeks ago or a few days ago, 3 months ago, whatever the case may be. Modifier 57 is only for the day prior to surgery or the day of the surgery that the decision was actually made. A lot of times you see in the hospital where a provider makes decision for surgery 2 or 3 days before, and then they continue to see the patient for subsequent level visits in the hospital setting until the surgery. Remember that unless they're seeing that patient for something other than what they're doing the procedure for, i.e., like a cabbage, if they're doing separately identifiable work, you can bill that subsequent level. But if all they're doing is seeing the patient and making sure their status has not changed until that surgery, those 2 visits in between the third day before and the day of are not going to be billable if they are only seeing the patient for subsequent level care directly related to the surgery that they will be performing within a day or two. Okay. I also want to talk about modifier 59. We're going to get in a much deeper conversation here in a few minutes on modifier 59, but just remember that modifier 59 is for procedure codes. This is not for evaluation and management services. So just make sure if you're new to modifiers or you're unfamiliar with some of these modifiers that we discussed today, that there are specific modifiers that are only for evaluation and management services, and then there are specific modifiers that are only for procedure services, including modifier 59. So just know the difference between your evaluation and management service modifiers and your procedure code modifiers. Let's see if we have any other questions.
I've got a question.
Yes, ma'am.
I'm an educator auditor And I have a doctor in sports medicine that is doing injections. And he's wanting to build a separate E&M on the same date that he's doing an injection.
Hmm.
And that's been our biggest problem, trying to get him to understand that if that patient is only coming in for that injection,
Hmm.
that's what we're going to bill. There is
Hmm.
a separate component of an E&M built in that injection code. Am I correct?
Correct.
But he says, well, I'm not going to be given an injection unless I evaluate the patient. And I'm like, well, that's not documented that you did anything above and beyond what the patient was coming in for. So my question is sports medicine always like that when it's coming in to try to get them to see that there has to be something that is separately identifiable that they can justify the report of that modifier 25 on an E&M?
Yes, so keep in mind to make sure that you remind your providers that the reason they get paid what they get paid for those trigger point injections or any other type of like a Synvisc injection or any other type of orthopedic type injection like that, they're getting paid RVUs, work RVUs based on that procedure. So, because it encompasses a portion of evaluating the patient, they're already getting paid for it. That's why it's included in the cost of the injection itself. So, in these cases where, especially with orthopedics, you have a provider that determines 6 months ago this patient needs to come back every 3 months for this knee injection, this shoulder injection, whatever. He's already told the insurance company, I know that this is the plan of care for these injections. The decision's already made. So, unless that patient is coming in and they're telling the provider that they're now having a different area of pain or a change in pain or some other acute um, issue that has come up or a severity change. So, let's say they come in and they tell the provider, hey, I know I'm here for such and such injection, but my pain has significantly worsened since the last visit, and the provider then has to do other workup. Maybe they have to order an MRI or a CT because of the severity. Those are the cases where the evaluation and management service is clearly separately identifiable. But if they come in that day and they're like, hey, okay, so we're going to do such and such every 3 months, and that day they come in and all the provider does is uh, initiate the treatment, there is no separately identifiable evaluation and management service that can be billed.
I agree. Thank you.
Yes, ma'am. Okay, so let me double check in the chat to see if we had any other questions. Okay, so if there are no other questions on modifier 25, we're going to go ahead and move on to our next modifier.
I have a question,
Yes.
please. The patient was at the dermatologist, and the dermatologist said the lesion needs to be removed. And then he referred him to a plastic surgeon to get that lesion to be removed. Now the patient is seeing the plastic surgeon in another day. The plastic surgeon document, yes, yes, this lesion needs to be removed, and he removed it in the clinic at that day. Now, do we bill the E&M with the 25 modifier and the excision code for the plastic surgeon? I mean, the decision for removing the lesion was, I mean, I know it's not done by the same surgeon, but do you consider this applicable? We can use 25 here for the
Um,
plastic surgeon.
Well, is the plastic surgeon and the other provider, are they being referred out to a separate, like billing under a separate tax ID or taxonomy code? If they're one group, say for instance, they have a different subspecialty, but they're in the same group under the same taxonomy or tax ID number, I would say no. But if they're referring them out to a separate um, um, specialty practice that is
Mm,
completely separate, then yes, I would say that both are billable.
okay.
So it depends on the scenario because if they're just referring them out just to have that one thing done, the decision has already been made, then I would say no. But if say for instance the provider, the plastic surgeon isn't the one going to be removing it and he's not sure and we're still in that um uh unidentified sign or symptom, like they come in for a mole and they're not sure if it's cancer, so they have to send them to a provider that's more educated, like a
Right.
dermatologist. That type of situation where the decision hasn't officially been made yet. Does that
Okay.
make sense?
Yeah.
Okay.
Thank you.
Yes, ma'am. I did have someone else that asked a question in the chat as it refers to a 10-day global. Yes, a 10-day global still requires the 57 modifier. The only thing you're going to put a 25 on is if it's the same day and it's 0 global days. So if I didn't clear that up earlier, hopefully that clears it up for the person that asked that question. Let me double check. I don't see any other comments at the moment. So getting back to what we were talking about a second ago about modifier 57. So I already covered most of it, but decision for surgery is specifically for procedures that have global days attached to them. So just remember that when your providers are making decision for surgery, and it can happen both ways. The first way is they make the decision 2 weeks ago and your provider wants you to add a 57 on it. You can't add a 57 for decision for surgery that isn't the day before or the day of. If they make the decision 2 weeks ago, great, but they can't come back the day of surgery and expect to get another evaluation and management service unless something has changed, worsened, or there was a different diagnosis assessed and treated on that day. So if they make the decision 2 weeks ago and they're coming in today to have the surgery done, they're not going to get another evaluation management service simply for, say, the admit to the hospital to have the surgery, or the H&P, a lot of people refer to it as. They're not going to get that separate E&M visit if there is not a reason that is significant from the surgery they are doing. So hopefully that clears that up too. That's a big question that a lot of people have, is the provider wants that H&P to be billed too. It's not billable unless they're assessing and treating something significantly separate from the surgery that they're performing on that day. I didn't wait, but were there any questions on modifier 57 before we move to the next one? I'm not seeing anything in the chat. Feel
I
free to,
have one.
yeah, go ahead.
Yeah, the patient was let's start at the beginning. The doctor decided for the patient to be admitted. Okay, he had some issues, and then there was a consultation note dictated by the APRN, and the APRN mentioned in the note that the neurosurgeon decided to have a surgery for that patient, and then the next day there was a surgery by that surgeon. Do we bill the E&M for the APRN with the 57 modifier? She's not the one who made the decision, but she documented that the doctor or the neurosurgeon decided to do the surgery the next day.
So did both the APRN and the MD both have a separate E&M
No.
service on the same day? So when did the MD make the decision for surgery?
Um, there is no note in the system that says the MD saw the patient, but you only see it in the documentation of the APRN that the doctor came in and then he checked the patient and he decided to have a surgery for the patient the next day or the same
Okay.
day.
If they're in the hospital and the provider did an appropriate attestation on the bottom of the AAPRN's note that he saw and made the decision, then you could bill a split shared service and you could get the 57 if it was the same day or the next day, because then it would be a split shared service where the
Okay.
APRN and the MD saw them. So if the MD puts an appropriate attestation that says, I saw this patient, we decided to move forward with the surgery, yes, you absolutely can get the 57 on that. But you want to add your FS as well, which we're going to cover in just a minute, for the split shared service, saying that the provider also saw them.
So we have to have his attestation there before we put the 57 modifier
Um,
for the APRN.
unless the APRN made the decision for surgery themselves, then I would not feel comfortable adding the 57 because we don't have like documented proof of when the doctor made that decision. They could have made that decision 3 days ago or 5 days ago.
Right.
We have no documented proof of when the decision was made. Now, if she specifically said the decision was made today, or the decision was made 5/4, and today is 5/4, or yesterday
Okay.
was 5/4, then that would be appropriate.
Okay.
Okay, did that answer your question?
Yes, it does. Thank you.
Wonderful. Okay, so we're going to move to FT. So modifier FT is an evaluation and management modifier that is specifically added for critical care services. So in a lot of times you'll see like cabbage patients or other major surgery patients, patients that have had heart transplants, lung transplants, all these kind of things that are currently in a critical state once they leave the OR, and they're going to probably be in a critical state for several days. So when the modifier FT is appropriate is for an unrelated E&M visit during the postoperative period on the same day as a procedure or another E&M visit. So let's say they have to see the patient, the provider or provider group practice specialty providers. It means only the practice that performed the global surgery, they have to see the patient for something unrelated to the procedure, and the patient is critical. So they're billing that 99291, 99292. If that provider or anyone in that practice that performed the procedure, they would put the FT modifier on that evaluation and management service. Remember, this is just for critical care visits. So it's your 99291, 99292. Now, if any other specialty, any other provider does critical care services while the patient's in global, it doesn't matter because it's only related to the provider or the other providers within that same specialty group that performed the global surgery. Does anyone have questions on modifier FT? Let's see. Oops, sorry you all. I didn't mean to move forward yet.
Yeah. Hey, Kristen, I'm so sorry. Where is this in HCPCS? Where is FT? I'm looking at my codes and I can't find a modifier FT.
I would have to go to the book. I don't have the book in front of me, but
Is
it's specific for critical care. So,
oh,
the first place I would maybe look would be the guidelines at the front of the critical care section in your CPT book. I don't have a specific page, but we can take it offline and look it up at a later time if you would like.
yeah, that's okay. It's okay.
Okay, so if we don't have any other questions on FT, we'll go ahead and move forward to our next modifier. Let's see if I had another question here. Joy said, what about Q codes? So we won't be talking about Q codes in today's meeting. And it looks like, I hope I'm saying this right, Gemaria stated it is in the HCPCS book, Ellen. Okay, so we're going to start with FS modifier now. Let me see if I have another question real quick. Okay, great. Modifier FS, as I was just speaking about a few minutes ago as it related to that decision for surgery example, modifier FS is specifically only for split or shared services, E&M services in the hospital setting. You would never use the modifier FS in the outpatient office setting. In the outpatient office setting, we would use incident 2 guidelines, which are not the same as split or shared E&M services. So for the purposes of today's meeting, we're specifically talking about the FS modifier and split shared services within the hospital setting. So split or shared services, an FS modifier is for evaluation and management visits where both the physician and the NPP can be a nurse practitioner, PA, whatever the case may be, they are splitting that visit, and the provider that performs the substantive portion, which means performs the majority of the visit. So if the NP goes in first and they do a complete note, and then the doctor does an attestation at the bottom that just says they agree with the NP's assessment and plan, that's not enough to get split shared services. The provider also has to have some type of encounter with the patient. It doesn't necessarily have to be face to face. It could be that decision for surgery. It could be changes in medicine. It could be any other work up on the patient as it relates to the examination. It can relate to the assessment and plan or any other decision made, and if they are owning the NP's work. So they say that they are not only in agreement with the MP's work, but they take responsibility for the MP's work. Then it has to be in an attestation in the note in order for them to get credit for the split shared service. If they are not doing a complete attestation and they're only agreeing with the MP's work, that is not enough to get a split shared service. Okay, so now let's say in the instance where the provider does give a little bit of information about them seeing the patient, but it's not substantial portion. You can still bill with the FS modifier, but you're going to bill it to the NP or PA, not to the MD. The MD has to put the substantive portion in order for the visit to be billed to the MD with the FS modifier. Now, there are some practices out there, and I want to make this clear, that there are some practices out there that prefer to just bill it to the NP, even if the doctor gave their attestation. Now, I want to make this clear though, the NP has to still do the substantive portion. If your practice decides that you still want to bill it to the NP, they can do that. On the converse, they cannot just bill it to the MD if the MD does not do the substantive portion. And I want to make that very clear because a lot of MDs want to get credit for it, and they can't if they're not doing enough of the work. It's not appropriate for them to get credit for the entire service if they're not doing enough of the service in and of itself. So, do we have any questions on the FS modifier? Feel free to come off mute or you can drop it in the chat. If not, we can go ahead and move forward with the next modifier. Okay, so we have covered the highlights of evaluation and management modifiers, and now we're going to get into surgical modifiers. Now, remember, none of these are all encompassing. I tried to pick the modifiers that I felt I get the most questions with. Okay, so there were a couple modifiers mentioned in the chat at the beginning that we will cover at the end. But other than that, hopefully I was able to cover the majority of questions you had. So for surgical modifiers, the first modifier that we're going to talk about is modifier 58. So modifier 58 is for a staged or related procedure or service by the same physician or other qualified healthcare professional during the postoperative period. So a really good example of this is when a trauma comes in, the provider has to do a major skin grafting of the patient. They're having to do debridements, and they put in the op note, we know that this patient's going to have to come back in 2 weeks for another debridement and then 2 more weeks for another debridement. And they're already in a global period from that grafting surgery they had to do because of how severe the burn was. So the doctor is telling you, they are documenting, we know that this patient is going to have to come back in for follow-up care directly related to this procedure. Remember, these are all procedure modifiers now. 58 is a procedure modifier. So if the patient has to come back for a staged debridement, then you're going to put the modifier 58 on it. Okay, so the examples would be the planned or anticipated stage procedure. If they're having to come back for a more extensive procedure than the original. Say the original procedure put them in global, but now they're having to do even more work because the patient declined or they had some type of complication or an additional issue happened and they're having to perform an even more extensive surgery related to the previous surgery. Okay, so there's another example on this we're going to cover in a minute, and that's modifier 78. So keep in mind that that's a different thing. Okay, also the third example would be for therapy following the surgical procedure. So just remember this is specifically for staged or anticipated. That's the biggest difference here is anticipated work versus unanticipated work. Okay, so are there any questions specifically on modifier 58? Okay, like I said, y'all come off mute if you have questions. You can drop them in the chat. I'm trying to check it periodically.
I got a question about modifier 58.
Yes.
Whenever you do another, say, stage, does that start the global period all over again, or does it change?
So you're saying that they did an extensive procedure that put them in a 90-day global, and then they had to do another procedure that also had a global on it.
Correct.
Correct. So you're going to have the global from the first surgery. So the first surgery, the global ends on whatever that day is. But when they do another global, you have to restart the global from the day that procedure was. So any follow-up from the original procedure will still end on their 90-day global period. But then when they do the second procedure during that global period, anything related to the second procedure specifically will end when that 90 days ends.
Okay, thank you.
Does that make sense?
Yes, ma'am, it does.
So
Thank
you
you.
just, yeah, you just have to make sure you're tracking your global period so you know when the provider is doing something related to the first procedure and when the provider is doing something related to the second procedure.
Thank you. That makes perfect sense.
Yes, ma'am. Okay, great. So I'm gonna go ahead and move on to 78. Remember, if y'all have other questions, feel free to jump in, okay? So modifier 78. So we just talked about modifier 58. That's for staged anticipated procedures. They already know this patient is going to have to come back. So with a modifier 78, this is when it's unplanned. Now, there's a difference between 78 and 79, and we're going to cover 79 next. 78 is when it's related to the first procedure that put the patient in global. So they're having to do another procedure unplanned but related. Modifier 79 is when it's unrelated. Okay, so just remember to use your modifiers appropriately. So when you have a modifier 78, this is when it is unplanned. They did not anticipate having to send the patient back to the OR, but they ended up having to, and the second surgery is related to the first surgery. Okay, go ahead.
Would this be if they, let's say they had a surgery for their knee and they ended up getting an infection because of the surgery for the knee, that would be this modifier, right?
Correct. Complications, adverse reactions to, or more extensive as it relates to it, but it's just unplanned and related to.
Now would that start the global period all over again, like we were talking about earlier?
Right,
Or
just like we mentioned a minute ago, if the second surgery also has a 90-day global period on it, you're going to have two different global periods you have to track. You're going to have the global period for the first procedure, and then you're going to have the global period for the second procedure.
Awesome. Okay, thanks.
Okay, now I do have a side note here. We're not going to cover modifier 76 like in detail because I did not create a slide for it, but I do want to make a very clear distinction. Modifier 76 is for a repeat procedure on the same date of service. So that means the exact same CPT code. That means if they did an echo, a complete echo this morning, that's not a global procedure, by the way, a 93306, and then they have to do a repeat echo later in the day, another 93306, that's when you're going to get that 76 because it's the exact same CPT code. Okay. If the procedure differs in any way with other CPT codes, you are not getting a modifier 76 because it's not the exact same procedure on the same data service. I just want to make that distinction because I do get some questions come up on that. Like if they had to do 2 cardio versions in the same day, they had to do a second round of CPR on the same day. All of those type of things are when you typically will see a repeat procedure on the same day because the patient fell back out of heart rhythm. I'm sorry, y'all. I'm a cardio person, so a lot of my examples are going to be cardio, so I do apologize. But there are other scenarios out there where a repeat procedure would be necessary. Just remember to use your 76 if it's identical CPT code and only on the same day. Were there any other questions on 78 before we move to 79?
I have a question.
Sure.
When I studied for the exam, the CPMA, I found a sentence that says 78 does not reset or restart the global period for the first procedure because it's
Not for
related
the
to the
first
first
procedure. It's not resetting the first procedure. It's making a new one.
Right. It's like what I mean is does not start a new global period.
Well,
That's what I read. I don't know. But 79 is because it's unrelated to the first procedure.
But if the second procedure has a global period on it, it has to have a global period attached to it.
Okay.
Does that make sense? Like if the second procedure they do doesn't have a 90-day global, it's not going to change anything.
Okay. I thought when I read that sentence, I thought even if it has a 90-day global, we still have to count the days from the first procedure that happened.
Correct.
Not the same.
You still count them, meaning if
because I see patients like in the they need shunt in their brain. So let's say in January the provider placed a shunt, and then there was a complication. The patient came in the global period, let's say before the 90 days is over. They made a revision of the shunt. Now, let's say they came in the last week of the 90 days global, okay? What I understood from that is like, okay, 78, you put the revision code and the 78, and you don't, it does not start a new global period 90 days again after the revision, is it? Or it should?
So what I just want to make sure that I'm understanding you. You're still going to have the global from the first surgery. That's not going to change. But if the second surgery is related to the first surgery and it does not have a global period, then no, it would not. Yeah. So it does not automatically start if it's specifically related to the first one. That's what you're saying, correct?
Yeah, if it's related to the first one, and the code has a 90 days global, which is the revision code has, so it should not start another 90 days global after the second procedure.
Right, but that is only from the original procedure. So when we use a 78, a modifier 78 is used, the original global period is not restarted. Does that make sense?
Yeah, it's not restarted. Yes, it's not.
Right, but that's only for the original global.
Okay, but we still need to count a new global period for the second procedure now.
Correct.
Okay, got it.
So anything related specifically to the first one will end when the first 90 days ends.
Right. Okay.
Does that make sense?
Yes.
Okay.
Thank you.
Yes, ma'am. Okay, so now we're going to talk a little bit about 79. So the difference between 78 and 79 is whether it is related or unrelated to the first global procedure. So if it is unplanned and unrelated, the modifier 79 is going to be the appropriate modifier to append. So they went in for a knee procedure and now they're having to go in for an ankle procedure. Okay, they didn't plan on doing that ankle and it's not related to the knee procedure, but they're having to do a second surgery. Therefore, you have to get the 79 on it. And remember, for all of these 58, 78, and 79, these are all as it relates to that first procedure. So the only providers that are going to be using these modifiers are the providers that are within the same practice, same specialty as the provider that performed the original surgery. So if your provider is an unrelated specialty and an outside practice from the original provider, you would not be using these modifiers. These modifiers are specific to the provider or provider practice specialty that performed the original surgery. Okay, so are there any questions on modifier 79? Okay, so I don't see anything in the chat, so we're going to go ahead and move to the next one. So modifier 22 is very heavily discussed. Okay, a lot of providers, especially your surgical providers, they want to put a modifier 52 on everything because they feel like their work constitutes getting paid more money. And that's not always the case. I'm going to tell you that modifier 22 is probably the most denied, not the most abused, because the most abused in procedure world is 59, but the most denied modifier. Modifier 52, your provider has to do a substantial amount of additional work, and they have to document exactly what that substantial amount was. They can't just tell you that they did say 30 minutes of extra work. What did you do in that extra 30 minutes? What was the increased intensity? What's the time? What's the technical difficulty? Did they have to change the sheath out multiple times? Did they have to use different catheter sizes? Were there issues because the patient was obese, or did they have a drop in blood pressure and they had to stabilize them, or did they have a bleed out or something that caused this procedure to be substantially more work? Was a procedure that normally is an hour and a half, it took them 3 hours. Why? What were they doing in that additional time that constitutes that modifier 22? Because I can guarantee you that if your doctor does not give an adequate amount of documentation as to why this was higher in difficulty, or increased the time, or in the intensity, or the severity of the patient, whatever the case is, if they do not document enough to support it, your insurance company is not going to pay for it. Okay. So are there any questions on modifier 22?
Yeah. So Kristen, did they take into consideration, what if this patient has had a stroke and they're getting a like a breast biopsy done and can't get out of the wheelchair, and you got to do they take in like the fact that the patient is extremely very, very ill versus a patient that just comes in for a biopsy when you use 22?
Well, you have to keep in mind that this is only during the procedure. So the fact that the patient was in a wheelchair doesn't have a direct effect on it. But if on the table, because they recently had a CVA, if they're having trouble moving the patient to the position that they need to, or they have to, it takes extra people to hold the patient in a certain position because they don't have use of their left side, or they're
Yeah.
completely, from the waist down, or whatever the case may be, the doctor still has to document that, that why was that so difficult to finish this procedure. So it doesn't really matter the before the procedure or after the procedure, it's what caused the procedure to be so much more difficult. Just like specifically with obese patients, they're having so much more difficulties getting through so many layers of skin and fat and all these other things. And sometimes it's hard to see certain organs or areas because the fat, the tissue is limiting them. So those are the situations where the doctor needs to document all this extra work that was necessary to achieve a goal of the surgery that would normally be so much more straightforward had it not be because of those other issues.
Okay. Thank you.
Yes, ma'am. Okay, so I don't see any other questions in the chat, so we'll go ahead and move forward. So modifier 50. So this is a laterality modifier. Also still a procedure modifier. It doesn't go on evaluation and management services, but specifically modifier 50 is your bilateral procedure modifier. So there are certain insurances like Medicare or some of your commercial payers that may have specific rules on whether they want the procedure to be one line on the claim with a 50, or if they want two lines and an LT on one line and an RT on the second line. You need to make sure that the company you work for, if you bill based on Medicare, you'll want to do it per Medicare guidelines. If you bill based on payer, you need to know what your payer guidelines are to make sure that you're billing it correctly. Because if they're the insurance company wants it billed on two lines with an LT and RT, they're going to deny that 50 modifier. It may still be appropriate, but their policy states that they want it to be two lines with an LT and an RT, not a 50. So just make sure you're aware of that when you're billing based on your company or your practice policy. Okay. So when we're talking about bilateral surgery, we have a few different indicators that we want to talk about. So a 0 bilateral surgery indicator is for a unilateral code. Therefore, modifier 50 is not billable. Okay. So if it is a unilateral code, meaning it only applies to a specific side of the body, then you can't bill a modifier 50. Indicator of 1 indicates that the modifier 50 is appropriate. So that's going to be our most common indicator you're going to see for procedures that normally allow either on the right side of the body, the left side of the body, or bilaterally if done. Remember, if done meaning the documentation has to support that it was in fact done on both sides of the body. But remember, on any laterality modifier on the entire body is, you have to think about it. Think about it logically. If the surgical code, if the procedure inherently has nothing to do with the side of the body, a laterality modifier is not applicable. Okay, so if you don't have two of them, it's not laterality specific. So if it's not two legs, two arms, two hands, two eyes, 2 feet, whatever, if it doesn't have anything to do with the side of the body, it is not appropriate to put a laterality modifier on it. So you just have to use logical thinking as the definition of the CPT code. So an indicator 2 indicates that it's a bilateral code and that it inherently encompasses both sides of the body. Therefore, modifier 50 is not billable. So in the CPT code itself, it tells you that it applies to both sides of the body. That's why you don't bill a modifier 50 on it. Bilateral 3 is like a primary radiology code where a modifier 50 is not billable. So there are, other codes out there that are allowed, but if the CPT code in and of itself includes both sides of the body, or if it's a radiology code where it's so many views or this, that, or the other, you have to follow your indicators. Okay, so the last indicator that we have is a 9. So a 9 indicates that the concept does not apply. And you'll see that with any of your indicators is that if it does not apply, that means the concept doesn't exist for it, for that specific CPT code. Okay, so there are certain scenarios where for instance, with a MRA study, that's a magnetic resonance angiography of the lower extremities. If it's performed bilaterally and the procedure has a bilateral indicator of 3, it should be billed with a 50, and it's specific to the that insurance company. So if the insurance company wants a modifier 50 on it, then you can apply it in order to get paid. There are other insurance companies that want the LT and RT on it anyway. So you have to bill it on 2 lines, one with an LT, one with an RT, because it's specific to payer guidelines. Okay. And just remember that Medicare would not allow this. So if your your practice, your company that you work for follows Medicare guidelines, you wouldn't put it on there. But if your payer does allow it and is only going to pay it with it, you can append it. Any questions about modifier 50? Okay, let's go ahead and move forward. We're running a little short on time, so I'm going to try to get through the rest of this fairly quickly. And remember, we'll talk about the slide deck as soon as we finish the recording. So with modifier 51, this is a modifier that I think a lot of people get trumped on or get tripped up on or whatever the case may be. So multiple procedures. So there are some practices or big companies now, the hospitals and stuff, where they have an edit in their system that automatically appends a modifier 51 to every line below the first claim line. Because remember, the way that works is that claim line 1 gets paid at 100%, and then every claim line after the first claim line gets paid at a reduced rate. So some insurance companies don't even want the 51 anymore because they're automatically paying at a reduced rate for every claim line after the first one. Also remember that modifier 51 is not applicable for add-on codes. Every single add-on code in the book has the red circle with the line through it telling you that it's not applicable because add-on codes require a primary code. So it doesn't matter. If you don't have the primary code, you can't build the add-on code anyway. Hopefully that makes sense. Are there any questions on modifier 51 before we move forward? Okay, so I saved the best for last, and I say that because there's also a lot of confusion with the X modifiers in 59. And if we run a little over, I hope that's okay with you all. You can give me a thumbs up or something in the chat if y'all are good with that, because we might be a little bit over the 1 o'clock time frame. So modifiers XE, XS, XP, and XU. Okay, so these were developed some years ago to further clarify the modifier 59. Okay, so 59 has been used and abused forever. Okay, so many providers out here want you to put a 59 on everything to unbundle them so they can get paid more money. Okay, well, if they did it, it's still abuse if the guidelines tell you that that less inclusive procedure is included. Whether it has a separate procedure indicator or it tells you in the definition of the code itself, whatever the case may be, we have so many providers out here that are like, I did this and I did this and I did this and I did this. I don't care how many of this you did. If the more extensive procedure includes the less extensive procedure, you cannot get it billed separately to make additional money. Okay, they want those work RVUs, and I get that, but we have to bill it appropriately. So if you know your guidelines and you know what you can and can't bill separately, if you're familiar with your procedure to procedure guidelines, which I highly recommend if you're not familiar with, you need to go on cms.gov and you need to look on the page. They have an entire page about procedure to procedure edits and column 1 and column 2 code bundling issues. If you look up your column 1 code and you find your column 2 code and it says that you can't bill them together or you can bill them with a modifier, you need to know the circumstances around when you can bill it with a modifier 59. And that's where these X modifiers came into play a few years ago. Okay, so hopefully that wasn't too muddy. I'm going to try to go into more detail, but I'm telling you right now that modifier 59 by far is the most abused modifier, even more than 25. It is the most abused modifier, and I'm going to tell you that the OIG and the AMA, everyone, this is always a topic because providers are abusing the privilege of the modifier. Okay, so let's talk a little bit about the definition of these modifiers. So an XE means separate encounter. Separate encounter means that they did a procedure earlier in the day, and then they had to bring them back at a separate encounter on the same day. So it has to be documented appropriately that they already were in the OR once, and this is a separate trip to the OR. Two procedures within the same procedure encounter, meaning the same time period. They did not take them to recovery and put them somewhere else. That means if it was performed at a completely separate encounter on the same data service, okay? So many providers are like, oh, we're going to put that XC on it because I did this procedure and this procedure. No. Tell your providers no, okay? It has to be a completely separate OR trip, completely separate, same data service. Then we have our XS modifier. That is separate structure. So that can be a different organ. It could be a different limb. It could be a hip and an ankle. It could be a wrist and a shoulder, separate structure. Okay. It could be a heart and a lung. It could be a stomach and a gallbladder. They're performing procedures on a different area. Okay. If the second procedure is directly tied to the first procedure and there is a billing edit keeping you from billing them together, whether it's inclusive or more extensive or separate procedure indicator, it doesn't mean that they're going to get the XS. It has to be distinctly different procedure. Distinct. That's the main word here. Distinct. Then we have an XP. That is a separate practitioner. Remember, this is still two different providers, not performing one complete surgery. I'm going to give you a good example, which we're going to talk about in a second, is if they have to bring a PA in as an assisted surgery, they don't get the XP because they're assisting on the same exact surgery. It doesn't count. It means a different practitioner did a different service than the provider that performed the other service. Okay. Then you have an XU. So this is probably the least used modifier, at least in my opinion, least used in the X modifiers, unusual or a non-overlapping service. So basically it's distinct and it does not overlap the usual components of the main service. So it may still be in the same area, but it doesn't include the elements that are in the other service. So it might still be on the heart, but it doesn't include any of the things they have to do for the other surgery procedure they're doing on the heart. So if they're overlapping, meaning they have to do some of the same components to get the second service, it doesn't count. Okay. Do we have any questions on the X modifiers before we move forward? We're going to be talking more about 59 as well, but specifically about what they mean and how they can be used. Okay, I'm not seeing anything in the chat. Feel free to jump in if you think of something you'd like to ask. So, proper uses of 59 and the X modifiers. So, the CPT book states that modifier 59 is a distinct procedural service. Okay. Under certain circumstances, it may be necessary to indicate that a procedure or service was distinct or independent from another non-E&M service. Remember, these are procedure modifiers, not evaluation and management modifiers. Has nothing to do with your E&M codes. Okay. Also, keep in mind, just like I mentioned earlier, there is appropriate use of the modifier 59 and the X modifiers, and there is inappropriate use. And you need to make sure that you know your guidelines, you know your procedure to procedure edits, you know your NCCI manual, and you know when it is appropriate to append the modifier 59 and unbundle those codes. Okay, so again, it just says when another already established modifier is appropriate, it should be used rather than a modifier 59. So if it's a different modifier or if an X modifier is more appropriate and the insurance that you're billing to accepts the X modifiers. There are some payers that don't accept the X modifiers, and in those cases, you're going to use your 59. Okay, so a little bit more about the proper use. So just remember your 59 and your X modifiers are procedure to procedure. That's what PTP stands for. Okay. Procedure associated modifiers. In order to bypass an NCCI procedure to procedure edit, unless the proper criteria for the use of the modifiers are met, okay, medical documentation must support the use of that modifier. So your provider simply saying they did these other procedures is not enough to append a 59 and bill for the second one. The reason that certain procedures have astronomical work RVUs is because they're getting paid for all the inclusive procedures, anything leading up to it, the opening of the site, the insertion of the catheters, the sheaths, the guidance, all these other things. If there is a NCCI procedure to procedure edit out there and it tells you these cannot be coded together, they can't be coded together. If they say they can, you better make sure it meets one of the other criteria, a different incision, a different body part, a different provider, or non-overlapping. And if you can't answer any of those questions to support it, you cannot use it. Okay. So again, CMS allows the modifiers, the 59 and the X modifiers. Remember, you have to study your column 1, column 2 codes. And I also put the two Medicare transmittals on here, CR 11168 and MM 11168. So you can always go back and you can check those out at a later time. Where did my resources go? Oh, I don't know how that happened, but I have two resource slides, one that's blank. But here are my resources for today's presentation. And I'll cover a couple of the questions that were in the chat from the beginning of the meeting. I apologize. I'm not sure who asked this question earlier. It was at the very beginning, but someone asked about modifier 33, and I didn't cover it in today's presentation because it's not like a widely used modifier. It is used in certain specialties prevalently, but not in every specialty. So modifier 33 indicates a preventive service was performed, okay? This means that the procedure that they're performing, they're not doing it because there's an issue. They're doing it as a preventive measure to hopefully catch something or make sure that something hasn't happened, okay? So these are going to be your mammograms, your colonoscopies, immunizations, or well baby visits where all they're doing is seeing a well patient. This is not for patients that are being seen for sick related issues or already have established conditions that they are currently treating. Okay, so hopefully that answers that question. A good example of this would be a patient that receives a colonoscopy as a preventive screening. Then you would bill your 45378, which is your colonoscopy code, with a modifier 33, and that just indicates to the insurance that this was a preventive surgery done. Also remember that modifier 33 is not recognized by Medicare. It's only applicable to private health insurance plans that comply with ACA. So you need to make sure that your practice or your company has specific parameters around Medicare versus non-Medicare. Let me see if there was another question that somebody mentioned earlier. We already covered the bilateral indicator that someone mentioned at the beginning, but feel free to come off mute if anybody has questions that either I missed or you thought of since earlier. I'm just looking real quick. See if I didn't.
Hey, Chrissy, sorry. I was just wondering if you could give me an example. Since 59 is the most abused, how would you see that as being abused? Like what do you see as the most common abused 59 modifier? Like what? Yeah.
Any column 2 code that that can be done as a second surgery that a provider thinks that he can bill for. Like with colonoscopies, if they do a colonoscopy and they have to remove polyps and they do one by snare and they do one by cold and they do one with what clamps, I can't think of the word I'm trying to think of, but just because they did different techniques doesn't necessarily warrant a modifier 59. Just like in the cardio world, if they do a cath a week ago and they tell you at the end of the cath, the heart cath, I'm saying heart catheterization, and they tell you, I'm bringing this patient back to have a PCI done next week. Well, the provider may do another cath as a look forward just to check things out. But if the situation hasn't changed or a increase in symptoms or a new symptom, they can't bill for a second cath. And a lot of providers are like, if I did the work, I should get it. They've already been paid for that work. If you do it just to look at the area before
Yeah.
you place something that you already knew needed to be placed, that's abusing the modifier 59.
Okay. Yeah. That happens a lot. I've seen it a lot of times.
All the time. That's why it's the most abused, and that's why the OIG and some of these other, big dogs in the coding world are heavily auditing these, and people are paying back tons of money and losing their licenses and their, all these other things because they think they should be able to get paid for everything. It's just,
Yeah.
you
Yeah.
know, it's just the way of life. I did see that you asked something on 62. So modifier 62 is co-surgeons. So co-surgeons mean that there's two parts of a procedure where one MD distinctly does this part of the procedure, and then the other provider does this part of the procedure, and they are not intertwined. They are doing individual portions of the procedure. So in the event of, say, like a TAVR, I believe, where you have to have an interventionalist and you have to have a CVT provider, cardiovascular thoracic, they perform individual components of that procedure. So that's when a modifier 62 is appropriate. But remember that you can only append a modifier 62 if the CPT code has the indicator that says that co-surgeons are allowed. So again, you have to know your indicators to know if you can even bill a 62 on a specific code.
Okay.
Okay.
Yeah. Okay.
And it looks like Elizabeth said, I have select coder to reference for modifiers and 57 isn't listed for a 10-day global. Let me go back. I mean, I know for sure that a modifier 57 is absolutely required for a for global of 90 days. So I may have misspoke. You are correct. I misspoke. Modifier 57 is only for a 90-day global, not for a 10-day global. So I do apologize. Okay, everyone, that concludes today's meeting. Again, for anyone watching this on the recording, I would greatly appreciate it if you would like and follow the Coding Corner on YouTube. You can hit the bell to be notified for whenever I post new videos. Once this is uploaded, I will also share this to the Coding Corner Facebook page. For those of you that attended the live call, you do have the ability to get the slide deck, and I will share additional details with you in just a moment. Thank you all so much for attending today's meeting, and I will now be stopping the recording.